Assalamu alaikum everyone. The next topic of discussion is Porphyrias. What are Porphyrias? Porphyrias are a rare group of inherited or less commonly acquired metabolic disorder in which defective enzymes impair the biosynthesis of heme in the liver and or bone marrow. Pathophysiology. In the presence of triggers, there is decreased enzyme activity in heme biosynthesis, so intermediates of heme production accumulates. They deposit into different tissues such as skin, and our livers, so symptoms occur. Increased urinary and fecal elimination, so metabolite can be detected in feces and urine. The specific intermediates that accumulate depend on which enzyme affected in the heme biosynthesis pathway. Classification, so they can be classified on the inheritance or the organ of accumulation. Inheritance, we have primary, which are inherited, or secondary, which are acquired. On the basis of organ accumulation, we have hepatic, which is more common, and other is erythropoietic variant, which is rare. Hepatic, we have acute and chronic. So acute intermittent porphyria and chronic, these are cutaneous. Acute are systemic. In chronic cutaneous form porphyria, cutaneous tarda is the most common. While in acute case, acute intermittent porphyria is the most common. Now on the basis of inheritance, so primary porphyria, which are hereditary enzyme defects, we have hereditary hepatic porphyrias. In hepatic, we have acute, chronic, and erythropoietic. Acute, we have all these types: acute intermittent porphyria, porphyria variegata, hereditary coproporphyria. These all three are autosomal dominant, while DAS porphyria is autosomal recessive. Chronic porphyria, so we have porphyria cutanea tarda, PCT, which is dominant, are acquired. Hepatoerythropoietic porphyria is autosomal recessive. Erythropoietic porphyria, so we have congenital erythropoietic porphyria, which is also known as Gunther disease, autosomal recessive, and erythropoietic protoporphyria, autosomal dominant. Then we have secondary. So secondary, we have secondary coproporphyria and secondary protoporphyrinemia. Secondary coproporphyria caused by intoxications, hepatic disease, blood disorders, infection, starvation, and secondary protoporphyrinemia is caused by anemia, alcohol, chronic heavy metal poisoning like lead poisoning. Now we should discuss Porphyria cutanea tarda, which is the most common porphyria. Peak incidence is 30 to 50 years of age. Steps involved in the heme synthesis: in mitochondria, glycine and succinyl-CoA combine to the enzyme delta-aminolevulinic acid. In the presence of vitamin B6 is a coenzyme and form the delta-aminolevulinic acid. The defect of this enzyme leads to sideroblastic anemia. Then this delta-aminolevulinic acid comes to the cytosol where delta-aminolevulinic acid dehydratase is converted into farfobilinogen. In lead poisoning, delta-aminolevulinic acid dehydratase is defective. Now the farfobilinogen is converted into hydroxymethylbilane linear tetrapyrrole through the enzyme farfobilinogen deaminase. The defect here produces the acute intermittent porphyria. Now the hydroxymethylbilane will be converted into uroporphyrogen 3 and uroporphyrogen will be converted into coproporphyrogen 3 through the enzyme uroporphyrogen decarboxylase urode, and the defect in this enzyme leads to porphyria cutanea tarda, PCT. Again, this coproporphyrogen goes to the mitochondria where it's converted into protoporphyrin. Then in the presence of enzyme ferrochelatase, the iron is incorporated into the protoporphyrin to form the heme. The defect in this enzyme ferrochelatase is due to lead poisoning. What is the etiology and pathophysiology? So there is a reduced activity of heme biosynthesis enzyme uroporphyrogen 3 decarboxylase. Uroporphyrin accumulates in the skin. Sunlight dependent skin damage occur. Chronic photosensitivity. We have two types, type 1 and type 2. Type 1 is acquired deficiency of urode, which is 80% of cases, while type 2 is inherited autosomal dominant and it's about 20%. What are the susceptibility factors of iron overload lead to increased hepatic iron store? PCT is an iron related disease. Primary cause which is genetic, is hemochromatosis, while secondary is acquired excessive iron supplementation, blood transfusion, and chronic kidney or liver disease. Iron indirectly enables the production of uroid inhibitors, so they increase the chances of developing the porphyrias. Other factors are alcohol, smoking, hepatitis C, HIV, hepatic steatosis, estrogen therapy, sunlight exposure. What are the clinical findings? So it's mainly a dermatologic disease. Characteristic cutaneous findings are blistering skin lesions, vesicles, bullous secondary to increased fragility of sun-exposed skin. So this is known as blistering photosensitivity. Scarring and milia secondary to impaired healing process. Hypertrichosis. It's a condition of generalized or localized excessive hair growth that does not follow a pattern of male distribution, in contrast to hirsutism, which follow the male distribution pattern. Then we will hyperpigmentation and scleroderma-like changes. What are the common locations of dorsum of the hand, face and neck, extensor surface of the forearm, and there will be red, brown, or tea-colored urine. Consider PCT in a patient presenting with blistering rash on sun-exposed skin. These are the different findings: excoriations, scars, blisters, deep ulcers, superficial ulcers, and these are different rashes, and these are the fluid-filled blisters. Now, diagnosis of PCT, so high index of suspicion is necessary as the symptom overlap with several other conditions. Consider PCT in adults with blistering rash on sun-exposed area, especially the back of the hand, and unknown susceptibility factor. Confirmatory studies, so first line testing, we have spot urine, we will have increased uroporphyrins, and in blood test we will have increased serum porphyrin. Serum porphyrin evaluation is required and preferred over urine in patient with renal failure and impaired renal excretion. Management, so the goal of therapy is to resolve the patient's symptom by reducing porphyrin levels. General measures, so avoid susceptibility factors, smoking, alcohol, estrogen. Advise patient on photoprotective measures including reducing exposure to visible light, example using large particle sunscreen. Treatment, phlebotomy indicated in all patients, and low dose hydroxychloroquine or chloroquine. Hydroxy is considered safer and advised over chloroquine. Now we will discuss acute intermittent porphyria. So it is the second most common porphyria and peak incidence 20 to 30 years of age. More common in females. Etiology and pathophysiology: autosomal dominant mutation with variable penetrance. Approximately 80 to 90% carriers are asymptomatic. Triggers are increased heme demand and biosynthesis. Impaired enzyme activity due to mutation of phosphobilenogene deaminase, previously known as uroporphyrogen 1 synthase. So accumulation of heme intermediates, phosphobilenogene and delta aminolevulinic acid, which leads to the symptoms. What are the triggers? So most triggers increase the demand for hemetic heme, thereby stimulating heme biosynthesis, which in the setting of AIP enzyme mutation result in the accumulation of heme intermediates. Medications, especially hepatic cytochrome P450 enzyme, which are used in the biosynthesis of heme, including anticonvulsants, sulfonamides, anesthetics, hormone therapy. Anticonvulsants like barbs and phenytoin. Alcohol, smoking, endogenous sex hormone, fasting, or crash dieting. Increased intake of carbs may alleviate symptoms, while fasting are the triggers for the symptoms of porphyria. Metabolic stress, for example, surgery, infection. Clinical features, so there are no dermatological finding in acute intermittent porphyria. Acute attack, so we will have GI symptom, neurologic abnormality, GI symptom, we have severe abdominal pain, which is present in about 90% of patients. Nausea, vomiting, constipation, neurologic polyneuropathies, non-specific pain, weakness, fatigue, paresthesia, paresis, seizures, respiratory paralysis, autonomic dysfunction, tachycardia, hypertension, increased release of catecholamine occurs, which leads to autonomic symptoms, psychiatric abnormality, hallucination, disorientation, anxiety, insomnia, and we will have red-purple urine here. Chronic symptoms, so most remain asymptomatic between attacks, chronic neuropathic pain, and depression, so increased risk of suicide. 5Ps is the mnemonic for acute intermittent porphyria, painful abdomen, polyneuropathy, psychologic disturbance, port wine colored pee, and precipitated by triggers like drugs. The skin is not involved in acute intermittent porphyria. Diagnosis. So diagnosis is challenging and high index of suspicion must be maintained. Consider AIP if typical clinical features are seen in the absence of other causes. For example, unexplained severe abdominal pain accompanied by muscle weakness and dark urine. Routine studies are often normal and specialized tests are done. Confirmatory study first-line testing, spot urine sample for heme precursor level. Parfobilinogen, so there will be elevated level 20 to 200. Normal reference range is 0 to 4 mg per liter. Delta aminolevulinic acid will also be elevated 10 to 100 while reference range is 0 to 7 mg per liter. 24-hour collection is not necessary for the diagnosis. Management of acute attack. So goal of therapy is to stop the acute attack as quickly as possible while providing support and symptomatic care. Hospitalization may be required and specialist hematology or hepatology should be consulted. So in treatment we have heme therapy. Mechanism is iron containing porphyrin that decrease the activity of delta aminoleukinate synthase, thereby decreasing heme biosynthesis and accumulation of intermediates. Glucose loading considered for mild attack or as a temporizing measure. Chronic therapy due to complexity, patient should receive evaluation by specialist at a designated porphyria center. Advise all patients on avoiding triggers and maintaining adequate nutrition. Screen for long-term complication, chronic kidney disease, hypertension, and HCC. Differential diagnosis. So we have PCT, AIP, and lead poisoning. In PCT, uroporphyrinogene 3D carboxylase. In AIP, parvovirinogene deaminase and lead poisoning, furochelatase and aldehyde are affected. Uroporphyrin accumulate in skin and urine. Parvobilinogene and aminolevulinic acid in blood. Protoporphyrin and ELA in RPC. Clinical features of blistering skin lesion on sun-exposed area, possible scarring, hypertrichosis, and or hyperpigmentation, red, brown, tea-colored urine. AIP, severe abdominal pain, nausea, vomiting, constipation, polyneuropathy, muscle weakness, paresthesia, hallucination, disorientation, anxiety, insomnia, tachycardia, hypertension, and red, purple, port wine colored urine. In lead poisoning, symptom of anemia, headache, paresthesia, fatigue, muscle weakness, polyneuropathy, encephalopathy, seizure, especially in nephropathy, Burton lines on the gums. These are purple, bluish line on the gums, severe abdominal pain, lead colic, constipation. Diagnostics: so spot urine, increased uroporphyrin, blood test, serum porphyrin will be elevated. In acute intermittent porphyria, spot urine samples so increase parvobilinogene and increase aminolevulinic acid. In lead poisoning, we will have microcytic hypochromic anemia, basophilic stippling of erythrocytes, rings, sideroblast in the marrow, which are usually the characteristic of sideroblastic anemia. The treatment: so avoid sun exposure, phlebotomy, low dose hydroxychloroquine or chloroquine in PCT, while hemine and glucose in the AIP, and succimer and dimercaprol chelating agents in the lead poisoning. Erythropoietic porphyria, congenital erythropoietic porphyria known as Gunther disease. It's very rare but severe etiology: autosomal recessive uroporphyrogen 3 synthase defect. Bone marrow heme biosynthesis impairment begin in childhood. Clinical feature of severe photosensitivity, hemolytic anemia leading to hypersplenism, bone changes, bone marrow hypertrophy, pathologic fracture, acral osteolysis, red stain bone, port wine colored urine. Management: no causal therapy, avoid exposure to sunlight. Erythropoietic protoporphyria, so is third most common form. Autosomal dominant defective enzyme is furochelatase. Clinical features: after exposure to sunlight, there will be cutaneous burning, urticaria, burning, itching, protoporphyrin, gallstones, and rare chronic hepatic involvement. Diagnostics: so increase protoporphyrin in feces and blood. Management: so protection from sunlight, alpha MSH, melanocyte stimulating hormone, or deoxycholic acid, cholestyramine, liver, or bone marrow transplantation. So that's all about porphyria.